and welcome to one more session on Recall Revision series for Global Academy of Medical Education. I'm Dr. Sunabha, your OBS GYNAE faculty. I did my MS from JIPMER followed by DNB. So I would specially acknowledge one of my friends who has helped me a lot in collecting the question and compiling them. I cannot take the name because of the non-disclosure agreement. Thank you. So let us start with the question, and I would start with the two very atypical questions that has been asked, and I have not seen this question being asked in any of the previous exams. It's about obstetric audit. So what is obstetric audit? Obstetric audit is when some unfortunate or unforeseen event happens in the maternity ward or in the labor room. A mother dies, a baby comes out bad, deeply asphyxiated, or something unprecedented happens. There is something called maternal near miss, when maternal mortality was almost about to happen, then fortunately been saved, the life is saved. So in such cases, we go through the history and case sheet. The department involves consultants and residents. Everybody sits together, goes through the case from the history, from the very beginning, and to what could have been done better, what could have been noticed, what could have been, what department thing could be changed. So that kind of a constructive decision and constructive discussion is being done. Remember one point, that the person involved in the care are expected to come out with the truth, but mostly we discuss what is documented, what is there on the papers, and usually the involved people are not allowed to present, because either they will be protecting themselves or they will speak out of guilt that they have done everything wrong. So that is about obstetric audit. So a detailed discussion about the patient, what went wrong. Yes, that's what the obstetric audit is. We change our approach as per the discussion. Exactly. Hospital management protocol is changed by this discussion. Yes, if something is seen not happening correctly, particularly in COVID times, sometimes we found that from this point to this point, this much delay is happening. So we try to cut short the delay, or in the department policy, like doing the admission, CTG is taking a lot of time, causing a longer queue in the casualty. So we changed our departmental policy to admission CTG to be done in the ward, or if only required. So yes, management protocol can be changed by this discussion. But this is not about any experiment in treatment or investigation. That is dealt by the ethics committee. Any experiment in treatment investigation is dealt with the ethics committee and not by the maternal mortality committee or the obstetric audit committee. So one more thing I would like to ask you, if this protocol word was not there, if not sure if it was there, so somebody is saying hospital management is changed by this discussion. Obviously hospital management is not changed by this discussion. So if protocol word was not there, then this would have been the answer. But I think the protocol word was there. So coming to the another question, this is very important nowadays, all those litigations and problems and how to defend yourself. So what are the obstetric events that can promote litigation? A fetal head injury or any obstetric injuries, whether to the mother or to the fetus, a splice mark of the scalpel, or a forceps mark, or a chignon, or an intracranial hemorrhage that happens because of faulty instrumentation, all these are liable for compensation. And mother also, if obstetric anal sphincter injuries and other maternal trauma also can be reported. But mostly fetal injuries are like they can demand compensation very easily. Yes, maternal trauma, as we have already discussed. Stillbirth or neonatal death can be prosecuted. There you have to defend yourself, that saying that there were risk factors, and adequate monitoring was done, that is most important. But if a neonatal death or a stillbirth or a deep asphyxia happens in the child, that is an issue that can be brought about to the court. But preterm labor is a normal, preterm labor is an absolutely unpredictable normal phenomena, normal complication that can happen to any woman, and that whether we were equipped to handle that kind of a labor or that kind of a baby that was born, whether steroid was given or not, whether Maxelf was given or not, whether tocolysis was indicated and was given or not. So these can be the question, but as such preterm labor cannot be a point of litigation. Coming to a direct question, correct sequence of lochia. So lochia is basically the discharge that a mother has immediately after delivery for roughly about 3 weeks time. For roughly about 3 weeks time, it is a peculiar fishy order, and all the products of retained, not the retained product of conception, like minimal parts of the fetal membrane and the uterine decidua that get sheds off during this time. So for the first 4 days, for the first 4 to 5 days, from postnatal day 0 to 4 day, there is blood cells come out. This is mostly RBCs that constitute the lochia, and it is known as lochia rubra, because it is red and it is rich in the RBCs. Afterwards, for another 5 to 10, so next 5 to 10 days, next 5 to 10 days, 5th to 10th day, okay, it becomes paler. It becomes paler, pinkish or brownish sort of color. So this is known as the lochia serosa, or yellow. This is known as lochia serosa. And afterwards, for about roughly 2 weeks, next 2 weeks, we can see the only mild secretions and the remaining decidual cells rich in WBCs come out, which is white in color, This is paling out. This is pale white in color. And this is known as the lochia alba, right? So if lochia rubra is persisting, that indicates sub-involution of the uterus, that the uterus is not contracting and the living ligature that myometrium provides is still not working, and the mother is still losing RBCs through the from her uterus, right? So lochia rubra, lochia serosa, and lochia alba. Remember, none of them they have a peculiar fishy smell, but none of them is malodorous. If they say malodorous or pus-like, then most common cause of it is retained gauze piece or undetected injury that has got infected. Coming to the next question, I think there was a question on TOLAC, that is trial of labor after cesarean, or trial of labor after cesarean, or trial of scar indications and contraindications. There was a question on that. I cannot get the exact recall options, but remember there are two things that need to be questioned when we discuss TOLAC contraindication. The contraindications for TOLAC can be discussed in two broad headings. One is obstetric contraindication for vaginal delivery. Like somebody had a cesarean previously, and now there is not any absolute reason not to allow her TOLAC from the surgery point of view, but she has a placenta previa. She has a grade 4 placenta previa or grade 3 placenta previa, or she has active genital herpes infection, or the baby is too big to come out vaginally normally. So if there is an obstetric contraindication of vaginal delivery, yes, that is a contraindication for TOLAC. There is one more important contraindication of TOLAC which I want to discuss here, is contraindication related to the previous surgery. So if the previous surgery, if she has undergone 2 LSCs, we generally don't allow her, even if she has undergone 2 lower segment cesareans, we generally do not allow her to undergo a TOLAC, but it is not per se contraindicated. More than 2 definitely contraindicated. More than 2 is definitely contraindicated. 2, none of us will allow, but textbooks say it can be allowed if she has undergone classical cesarean. If she has undergone classical cesarean, or there was angle extension, to upper segment. If there was angle extension to the upper segment, if there is colporexis, like angle extension below, reaching to the vagina, or if there is a history of chorioamnionitis, because of the infection, the wound may have not healed to a wound strength that would allow vaginal delivery and will not rupture. So, history of chorioamnionitis. So, these are the contraindications which are related to the previous surgery. Remember, layers of closure. Either we close a 1 layer or 2 layer. Either we take interlocking bite. Either we take a interlocking bite or continuous non-locking bite. Has nothing to do with the nothing to do with allowing for TOLAC or not. These are not factors. These are not factors. Remember, the third point I'm mentioning here, and the most important perhaps, is consent. So, if it is entirely the woman's choice whether she wants to undergo TOLAC or not. So, if she is not willing for TOLAC, however obstetrically feasible, we cannot allow TOLAC. So, the first thing, that is, the lady should be willing for TOLAC. Okay, coming to the next question, oxytocin is contraindicated in which of the following situations? So remember, actually oxytocin in labor has very less contraindications, and in almost all cases, including breech, previous cesarean, wherever we can expect that vaginal delivery is possible. Whenever we see that a vaginal delivery is possible and the uterine tone, uterine contractions are not adequate, enough Montevideo units are not reached, we can do an oxytocin augmentation at a varying dose. Previous cesarean, grand multipara, nothing is a contraindication. So the basic contraindication of basic contraindications of oxytocin is when the uterine contraction is adequate or more, there is hyperstimulation. Then when there is a fetal distress, whenever the fetal distress happens, the first part of intrauterine resuscitation is stop any oxytocin, right? Whenever there is a fetal distress. Then of course, when vaginal delivery is not possible, that is one indication for not giving oxytocin. So these are basically the contraindications, or when the situations when we don't give oxytocin. Heart disease, preeclampsia, hyperthyroid, nothing exactly are contraindication. Unfavorable fetal position here actually indicates that a fetal position such as when the vaginal delivery is not possible. Actually, I looked up in the FDA drug information booklet on pitocin or oxytocin. So they have exactly mentioned this word, unfavorable fetal position. So this becomes our answer. They have asked one question about effective for how many years. About one intrauterine copper devices was there. As far as I have heard, that it was an image based question and this image was given. So this is copper T200. This is copper T. This is copper T200 that was previously recommended by Government of India, and this was there for 5 years. If you had this in the question with a thicker coil of the copper and copper also on the arms, so this is copper T380A. This number is the total surface area of the copper in centimeter square. So copper T380A. So copper T380A acts for 10 years. This one is multi-load. This one is copper 375 multi-load, currently recommended by the Government of India along with CU380A. So this was previously recommended by Government India. These are currently recommended by Government of India. Uh, this is for 5 years. This is for 5 years. So another intrauterine device. I'm pretty sure this was not the option. Just I want to show if they have. This doesn't have this safety device. This is rounded because this is rounded because so that this does not perforate the uterus, right? So if you see something like this that has perforation prevention bulge in the junction at the tail and the sides are bent without any copper on the arms, this is a latest intrauterine copper device. It is known as the CU safe, right? CU safe. So this is new, just that's why I wanted to show the image. Coming to the next question, post vasectomy contraception to be used for how long? So basically what happens is, I kept this image for a reason. So we do the vasectomy at the level of the base of the scrotum. So this portion of the tube, this proximal portion of the tube is actually spared, and the sperm that is present in this area are still functional and still alive and viable. So they can go into the vagina after unprotected ejaculation and can impregnate the woman, causing vasectomy failure. So it is recommended to use other methods of contraception until this reserve gets over. So how long do we need to wait? So this is what I have looked up in the latest NHS guideline or NHS public information bulletin that says 8 to 12 weeks they need to use a barrier contraception. 8 to 12 weeks they need to use barrier contraception. It takes roughly about 15 to 20 ejaculations to get rid of this, to exhaust this reserve, and two consecutive semen tests showing azoospermia is of course the gold standard, that the reserve is over and now the vasectomy is working and the man is rendered sterile, right? So this was a rather simple question. I think parts of the fallopian tube were asked. So the part which goes deep inside the uterus till the level of the ostium, tubal ostium, the layer which is inside the uterine musculature, inside the myometrium, is known as the intramyometrial part or intramural part, right? So the next part, the thinnest part, is known as the isthmus. The next quite longer and broader part is known as the ampulla, and this is the site for fertilization of the ovum by the sperm, and this is also the most common site for tubal ectopic. Almost 80% of the ectopic pregnancies happen in this area, this ampulla. Also, this is the site for sterilization, right? If we have to ligate a tubal, that is we do at the level of the ampulla. So after ampulla comes the broader part of the fallopian tube, which is known as the infundibular part, and the end of the infundibulum is associated with finger-like projection known as the fimbria. Okay. So coming to a rather complicated question, what type of hysterectomy is to be done for cancer cervix stage 1B? So before going to cancer cervix 1B, let us first discuss the types of hysterectomy. So when we do the hysterectomy at the level of, we cut the we cut the cornual structures at the end of the, just right at the cornu. Suppose this is the uterine artery and it goes through the myometrium. So we cut the uterine artery right where it ends, and we need not to dissect the ureter. We just need to identify the ureter, which is going somewhere here, passing under the uterine artery, because water under the bridge. So we need to identify the ureter, but we need not to dissect the ureter too much, and we just put our lower clamp at the level of the cervix, and we only take out this part, the uterine corpus and the cervix, ligating at the base of the at where the uterine artery just supplies the uterus. So this is known as simple hysterectomy. So along with simple hysterectomy, when we also remove the serosa of the bladder or just scrape out the peritoneum from the bladder surface as well, it is known as the extrafascial hysterectomy. Of course, both these procedures can be added with bilateral salpingo-oophorectomy, which is removal of the tubes and the ovaries bilaterally. But for simple hysterectomy and extrafascial hysterectomy, bilateral salpingo-oophorectomy is not a mandatory step. It is done based on a clinical indication. So, if we do more radical surgery, then we have to dissect the ureter. We have to dissect the ureter till the level where it drains into the bladder. Till the level where it drains into the bladder, it will be fully mobilized. It will be fully mobilized, and the uterine artery will be ligated in the midway between its origin from the internal iliac artery, and its entry into the uterine myometrium. So somewhere in the midway, it will be cut, and parametrium will be partially removed. At least half of the parametrium is removed, and BSO becomes a mandatory step here. Along with that, the vagina is dissected till the upper one third, right? So this is known as the Warthime's hysterectomy or modified radical hysterectomy. So Warthime's hysterectomy or modified radical hysterectomy. So now let us see what is radical hysterectomy. So radical hysterectomy is the most radical surgery where the entire BSO is obviously there. The entire parametrium is removed. Uterosacral till the pelvic side wall, the parametrium is removed. The uterine artery is ligated right at its origin from internal iliac artery, and the ureter is fully dissected and mobilized, and this was upper one third. 3/4 of the vagina is removed. This is modified radical. This is radical. The modified radical is also known as Warthime's. So this is modified radical. This is radical. 3/4 of the vagina is removed, right? So above this, this is called the radical hysterectomy or the extended hysterectomy. After that comes pelvic, the ultra radical surgeries, where we remove the distal ureter and re-implant the ureter into the bladder. There are several types of classification. If you find there are some other classification or some different thing that I am telling, something is a bit different from what I am telling, there will be class 1B, class 2 hysterectomy, class 3 hysterectomy, or type A, type B, type C. So because there are several systems of classifying hysterectomy in but basic, what I have discussed here is basic simple hysterectomy, extrafascial hysterectomy, modified radical hysterectomy, extended hysterectomy, and ultra radical hysterectomy. So this is the basic concept. Now with that, let us go to the surgeries for C cervix 1B. So initial stages, we have the options for fertility sparing. So those who want to keep their fertility preserved, there are surgeries for them, and there are surgeries for those who don't want to preserve their fertility. So if it is a stage 1A, that is micro-invasive, reaching up to depth which is less than 3 millimeter, with no lymphovascular stromal involvement. simple conization of the cervix is a treatment that can be sufficient. But if the lady is not willing to keep her uterus, a simple hysterectomy can also be done. So, if it is still stage 1A but lymphovascular stromal involvement is detected, or it is 1A2, that is still microscopic lesion but the depth of the invasion is till 5 millimeter, we need to do the Vardheim surgery. But if she is willing to preserve the fertility, atypical surgery is required, which is known as the Dargent operation or radical trachelectomy, where the cervix is amputated along with the parametrial region of the cervix, ligating the uterine artery somewhere here, but the rest of the uterus and bilateral tubes, ovary are preserved. This also requires dissection of the ureters and mobilization. So this is Vardheim surgery versus Dargent operation, which is radical trachelectomy, fertility preserving. Remember, this definitely causes short cervix and cervical insufficiency or incompetence leading to preterm birth unless McDonald's suture or Shirotkar's sacrilege suture or abdominal sacrilege is not taken. So coming to the next stages, since we are discussing stage-wise management of CA cervix in this opportunity, stage 1B1, which is a visible lesion less than 2 cm, 1B2, which is a visible lesion which is more than 2 cm or more, which is 2 cm or more, but less than 4 cm, not reach the size of 4 cm, because 4 cm is the marker for inoperability in CA cervix. So less than 4 cm, or 1B3 is visible lesion limited to the cervix which is more than 4 cm. So this is called early bulky disease, and this is non-operable, right? So next stage is 2A1, where the spread has happened to the vagina but the lesion is still less than 4 cm. So that is still operable. The surgery is radical hysterectomy with pelvic lymph node dissection. No fertility preservation is possible beyond this point. And if it is early bulky disease or a disease which is advanced to more than 2A1, that is 2A2 to 2B, 3C1, 3C2, some people says 4A also can be amenable to chemoradiation. 4B, definitely the main management is chemo. Role of radiation is only limited when there is an urgency. So for hemostatic RT, to stop the bleeding that is happening, that RT can be used, but the most main curative intent, the treatment is not radiation. When it becomes stage 4B, some people consider entire stage 4 in this stage, particularly depend on where the lesion is or how much radiation. But that is mostly clinical discretion. So let us not go into this controversy, and remember, still stage 3 it is chemoradiation and stage 4 is chemo plus minus hemostatic RT if required. So this is a classic question in obstetrics, the types of pelvis. So this is a gynecoid pelvis. You can see smooth roundish inlet, parallel pelvic walls, and a very big sacrocytic notch, roomy sacrocytic notch, right? So this kind of pelvis is most common and seen in about 50%. The next commonest is anthropoid, the monkey type. Yes, we are descendants of monkeys. So this is about 25%. This pelvis is anteroposteriorly long and bispinous diameter, or the lateral diameters are compressed. it becomes roomy as it goes down. So there is a divergent pelvis and a roomy sacroiliac notch. Roomy sacroiliac notch. So this pelvis, once the brim is cleared, the baby will definitely go, because the space increases down here and there is no lack of space at this point. So this kind of pelvis sometimes is what is known as a brim trial. What is known as a brim trial? We let in early labor we wait and watch that if the head is negotiating the brim or not. Once the brim is passed, we are sure that the baby will go for vaginal delivery and we go ahead for the labor. This is one very problematic pelvis which is seen in 20%. This is often encountered pelvis. This is android pelvis or the male type pelvis. So male type pelvis, the problem is this curve is not smooth. This is kind of jutting forward. Right, this is kind of jutting forward. So the sacrum is deep inside the pelvis and it gives rise to a pelvic inlet which is heart-shaped. Right? Pelvic inlet which is heart-shaped, and it is a convergent pelvis also. So if the baby goes down, it has a chance of getting stuck here as well. The suprapubic angle is narrow and the sacroiliac notch is also narrow. This is a particularly problematic pelvis and it is not very uncommon. You can find it in 1 in 5. Right? Not that this cannot deliver a baby, but you have to be very vigilant and take up a cesarean whenever the signs of cephalopelvic disproportions are evident. So this is one other type of pelvis which is known as a platypeloid pelvis, or the duck type of pelvis, or the flat pelvis. This pelvis is basically supero-inferiorly compressed. These pelvis are really deep. See, this is only this much. These are like this. These are deep pelvis. This is a shallow pelvis. So this is the rarest and seen only about less than 5% of the cases. And this has a mechanism of labor which is known as asynclitism. So the mechanism of labor through this pelvis is asynclitism. So let us take this opportunity to discuss some abnormal pelvis. So even if a gynecoid pelvis, it's not actually have to be good every time. A contracted gynecoid pelvis or a very small gynecoid pelvis is also abnormal. Anthropo, andro and platy we have discussed. So let us just discuss Robert's pelvis and Naegeli's pelvis. So this is sacrum. This is the sacral promontory. These are the two ala of the sacrum, and here comes the hip bone. Here comes the hip bone or the innominate bone to the symphysis pubis. So this is basically what is the pelvic inlet is made of. So if one ala is absent and the innominate bone has to directly form a joint with the sacral promontory. The pelvis is flat on this side and spacious on this side. So this is known as a Naegeli's pelvis, where if ala is absent on both sides, so both sides it is compressed, that is known as a Robert's pelvis. So Naegeli's pelvis, one ala absent, Robert pelvis, no ala. Okay. Triradiate or rachitic pelvis is seen in osteomalacia and rickets. If there is a skeletal deformity, kypho or scoliosis of the spine, then the pelvis is bent accordingly and can cause difficulty in the birth canal, can cause an abnormal curve of Caris. And post-polio residual paralysis is very interesting. So this is somebody with a post-polio residual paralysis with a normal leg this side and a thin atrophied leg on this side. So the most of the weight bearing has happened on this side. So this side pelvis will be more bent inside. This side pelvic curve will be normal, but this side pelvic curve will be inward because of the weight bearing solely on this for a long period. So that is about PPRP. PPRP are known to cause cephalopelvic disproportion in labor, and need to be assessed. Achondroplasia is a condition which is known to give rise to a pelvis which is known as a champagne glass shepherd pelvis. Just for the completion of the list. Okay. 32-year lady presented with frothy malodorous discharge. Wet mount shows this. So this is a trophozoite. This is a trophozoite of Trichomonas vaginalis. Trichomonas vaginalis. Remember, Trichomonas vaginalis is a obligatory pathogen which cannot live outside the human body. So their life cycle goes from one human to the other human. So this is a disease which is STI, which is actually transmitted infection, and needs partner treatment whenever requirement. So let us just see whether we can answer this question, without knowing what this image is all about. So let us discuss vaginal discharge. We need to see few things: itching, odor, and color. Right? So our candidates are bacterial vaginosis, Trichomonas vaginalis, and Candida. So Candida is known to cause itching, and Trichomonas vaginalis also causes itching. Bacterial vaginosis doesn't cause itch. Bacterial vaginosis causes fishy odor. Trichomonas vaginalis causes fishy odor. Candida doesn't cause any odor. Bacterial vaginosis color is grey. The discharge is grey and thin. Trichomonas vaginalis is greenish. It's very pale green actually. Greenish, frothy, and Candida is thick, cardy white. Also, Trichomonas vaginalis, special point of mention that it causes strawberry vagina. Strawberry vagina because of the severe itch and inflammation. Strawberry vagina. So, we have odor and we have a frothy discharge. So, you can see that we can work up to the diagnosis even without knowing the picture, and the picture is particularly confusing because the next best contender that can be there in the question is this one, where you can see a epithelial cell started with multiple small pathogenic cells, and this one is known as clue cell, which is suggestive of bacterial vaginosis. Bacterial vaginosis. Or you can see the fungal hyphae, which will suggest you the diagnosis of fungal infection or candida infection, right? So this is how you can decode the images, but without the images also we can from the history and the clinical findings we can work up to our diagnosis. So coming to the next question, second gravida with 2-year-old child fully immunized in last pregnancy with tetanus and diphtheria toxoid. So what vaccination is suggested in this pregnancy? The answer is simple, it's TD booster. It's TD booster. Because booster is indicated whenever it is less than 3 years. When somebody has taken the complete course less than 3 years back, then they need to take only one dose booster. If it is more than or equal to 3 years, then 2 doses of TD is again required, right? So that's a simple question. Coming to the clinical question. Examination of a 26-year female with progressive dysmenorrhea and dyspareunia. So remember this word, progressive dysmenorrhea and dyspareunia reveals fixed retroverted uterus. Fixed means there is adhesion, and nodularity of the uterosacral ligament. So something is there in the uterosacral, something is infiltrating the uterosacral ligament. Now let us work up the diagnosis. As I always say, try to rule out the options rather than trying to find out the correct answer. So PID will have dysmenorrhea, but more than that it will have dyspareunia. But if it is PID, then chronic abdominal pain and discharge would be the thing that would be in the question. So that is ruled out. Genital TB. If genital TB was the question, then it should come with all the suggestive features of tuberculosis. The weight loss, the cachexia, the evening rise of temperature, lost appetite, infertility, all these options will come into it. And tuberculosis is not known to cause dysmenorrhea. Tuberculosis, because it erodes out the endometrial from its basal layer, basically causes endometrial ablation and it causes amenorrhea. And dyspareunia is not a feature of tuberculosis because tuberculosis is a bloodborne infection that goes to the genitalia rather than an ascending infection. So, infecting the vagina and the lower part of the reproductive tract is less common with tuberculosis compared to the other forms of PID. So that keeps on our table to close diagnosis, adenomyosis and endometriosis. Endometriosis is abnormal endometrial tissue outside the uterus and adenomyosis is endometrial glands within the myometrium. So here what we can see, it is a progressive disease and that has progressed to the uterosacral ligaments. Now adenomyosis cannot go to uterosacral ligaments. Both are known to cause dysmenorrhea. Both are known to cause dyspareunia. Dyspareunia is slightly more common with endometriosis, but when they are talking about uterosacral ligament and a progressive disease, adenomyosis is ruled out because it's a local disease. So endometriosis is our answer. Laparoscopic ovarian disease is a management of polycystic ovarian syndrome or disease, PCOS or PCOD, which is also known as Steen-Leventhal syndrome, which is also popularly known as Hyran syndrome, hyperandrogenism, insulin resistance, acanthosis nigricans. So, Hyran syndrome. Remember the diagnostic criteria for PCOS is Rotterdam criteria, and 2 out of 3 criteria has to be fulfilled to call it a successful diagnosis of polycystic ovarian disease. I am not going into the details of the laparoscopic ovarian drilling surgery as well because I didn't expect this question to come, because laparoscopic ovarian drilling is a procedure of the bygone days and nobody actually does it, and it is proven beyond doubt that this doesn't have much improvement in PCOS fertility. This is basically when we do it with the heat and the power instrument, this reduces the ovarian reserve size. So nobody does this surgery, nobody recommends this surgery anymore. But anyway, this question is of historical importance, so I am not going into the details of the drilling. Coming to the next question, 40-year-old woman with postcoital bleeding. Postcoital bleeding, whenever you read it, rings a bell cervical cancer, because cervical cancer, cervix is there, touch on bleeding, so that coitus happens, the penis hits the lesion and blood comes out. So that is what comes to our mind, postcoital bleeding. But postcoital bleeding can also be in cases of atrophic lesions or any other active active bleeding or active breach of the mucosa, and it can also happen that the blood was stored or the bleeding was minimum, and because of the friction, because of the trigger, the blood which was bleeding from somewhere else is coming out. So, or the minimum collection of blood which was there inside the endometrium is coming out. That is a possibility. So, don't make your mind like postcoital bleeding, CA cervix. No, it's not like that. So, per abdomen, we found a solid right adnexal mass. When we are finding a mass in the per abdomen rather than bimanual examination, the mass has to be big because it has to come out of the pelvis to be palpable per abdomen. So, they have given the imaging endometrial thickness of 15 millimeter. She is a 40-year-old woman, so 15 millimeter thickness is plus minus. It's not grossly abnormal. Um, in postmenopausal women, the thickness cutoff is 4 millimeter. So if it is 4 millimeter or more, it is grossly abnormal. But 40-year-old is plus minus. So adnexal mass of 8 centimeter. So 8 centimeter, it's a big mass and it is solid tumor. Solid tumor. Endometrial biopsy was done and it has found grade 1 endometrioid adenocarcinoma on the background of complex atypical hyperplasia. So something is triggering the endometrial lining. There is a hyperestrogenemia. Definitely there is excess of estrogen that has unopposed estrogen I would say. Something is there causing unopposed surge of estrogen which has caused the complex atypical hyperplasia and later on which turned into the grade 1 endometrioid adenocarcinoma. So let us see the options now. Endometrial metastasis of ovarian malignancy. See, we don't have a ovarian malignancy in the picture, so ruled out. We cannot say something is a malignancy unless we have a biopsy proven malignancy. So concurrent endometrial and ovarian malignancy also ruled out. Next is ovarian mets of endometrial primary. Now this can be a possibility, but we need to understand that we have not yet found the source of the unopposed estrogen, and a very possible plausible source of estrogen is a estrogen secreting tumor somewhere in the body. And which is the cell that secretes uterus in the body? Granulosa cell. So a granulosa cell tumor, if it's the granulosa cell that is the source of the tumor, what is the site? Ovary. Granulosa cells are in ovary. So site is ovary. What kind of a tumor is granulosa cell tumor? It's a solid tumor of varied size. It can be very small, like a small grain, or it can be a large solid tumor. Nonetheless, a solid tumor. So it is a ovarian solid tumor that secretes estrogen. So here, if we see the granulosa cell tumor, everything fits. Everything fits. So this will be our answer. Now, yes, granulosa cell tumors are malignancy. So concurrent endometrial and ovarian malignancy is not a wrong answer. Not a wrong answer. But this is obviously not the single best answer because ovarian malignancy is not proven. Ovarian malignancy is not yet proven, but everything fits into the diagnosis of a granulosa cell tumor because granulosa cell tumor most often is diagnosed with a postmenopausal bleed or a raised ET on screening. What I'm trying to say is granulosa cell tumor is often not diagnosed as a tumor first, but as the endometrial hyperplasia first. Then when we do imaging and try to work up that endometrial hyperplasia, we found out, oh, there is something is suspicious in the ovary. Coming to the next question, most common indirect cause of maternal mortality in India. Remember, anemia. So anemia causes problem in the fetal development, in mother's development, in uterine development, everywhere. It causes FGR, it causes preeclampsia, it leads to everything. And then during delivery, it can cause all sorts of problems that are possible. And after delivery, these ladies are more prone to develop PPH and subinvolution and delayed repair of the sutures, whether it's a cesarean or a vaginal delivery with episiotomy. So anemia is a certain factor that leads, like, that can cause problem at every bit of pregnancy, right? So anemia is the most common indirect cause of maternal mortality in India. Remember, less than 11 gram percentage is defined as anemia, and only 10 to 11 is mild. Only 10 to 11 is mild. 7 to 9 is moderate. Less than 7 is severe. There is a controversy about introducing the level of very severe. So as per Government of India, less than 5 is very severe and requires urgent transfusion irrespective of the gestational age. Level of uterine fundus immediately after normal delivery. So we were talking about sub-involution when we were discussing lochia. So we need to know this so that we can understand that if the uterus is involuting properly, if it is retracting properly, or there is a incomplete retraction leading to bleeding or other problems. So immediately after delivery, this should correspond at the level of the umbilicus, which is corresponding to 24 weeks of gestation, which is correspond to a 24 week gestation uterus. And by 10th day, every day it should go down by one finger breadth, it should retract every day, and by 10th day it should become absolutely pelvic or just palpable, or which we call the level of the 12-week pregnant uterus, right? So it should take 10 days, and the involution is completed, like the uterus goes back to its normal non-pregnant size at 6 weeks. So 6 weeks is complete. So it is pelvic by 10th day, and immediate postpartum it is at the level of umbilicus, which is 24 weeks. After 10 days it is at the level of just palpable, or it just become pelvic. That corresponds to a 12-week uterus, and after 6 weeks the involution should be complete. When to initiate the breastfeeding in case of an uncomplicated normal delivery? I am not very sure what were the options and from where the examiners have picked up the question, but we'll discuss about something called baby friendly hospital initiative, which says all uncomplicated mother breastfeeding should be started within 1 hour. Okay, that is not 1 hour after. Best thing is latch the baby immediately after delivery, even before cutting umbilical cord, right? That is the best thing. But when we are doing mostly possible when we are doing cesarean, so as soon as possible, but at least within 1 hour is the baby friendly hospital initiative. Previously it was different for vaginal delivery. It was different for vaginal delivery on CS. It was less than within 2 hours in case of cesarean and within half an hour for a vaginal delivery. But current baby friendly hospital initiative, it's a 10-point program that you should know and should go and read now. I'm not going into the details of this now. So baby friendly hospital initiative, it is 1 hour irrespective of the mode of delivery in uncomplicated cases. Whether it's an uncomplicated cesarean or an uncomplicated vaginal delivery, breastfeeding has to start within 1 hour. So this is old, this is new, and I'm not sure of the options. But if you have this option, then they are aware of they have asked the question with this intent, so this is the best answer. In an uncomplicated primary gravida, what is the favorable rate of dilatation of cervix? Again, a classic OBS question. So let us just see this table from Williams. So protraction or slow dilatation, protracted or slow dilation is when it is less than 1.2 centimeters per hour in case of nulliparous and 1.5 centimeter per hour, less than 1.5 centimeter per hour in case of multiparous. That is called slow, right? So here the options, uncomplicated, what is the favorable rate? Favorable rate is 1.5 centimeter per hour, but since it is not there, 2 centimeter per hour is 2 centimeter per hour is next best possible answer according to me, because it should at least be, if it is less than 1.2 centimeter, it is protracted active phase dilation. So anything less than 1.2 is abnormal. So 1 cannot be the answer, 0.75 cannot be the answer, 0.5 cannot be the answer. So 2 is the only thing that is remaining on board. Now, previously people used to take 1 centimeter for primary and 1.5 centimeter for multi. So, if they have asked this question with that intent and from that edition of the textbook, they might have been expecting an answer 1 centimeter per hour. I am not very sure about it, because that was the old thing, 1 centimeter per hour for primary and 1.5 centimeter for multi. But as you can see, this table is from latest edition of Williams, and Williams clearly says less than 1.2 centimeter per hour is protracted for primaries, and hence 1 centimeter is definitely abnormal as per the current guideline given by Williams textbook. So my answer would be 2 centimeter per hour. So this is another image based question. I think you were given this image of a long instrument, and this is often confused with the IUI cannula. This is often confused with the IUI cannula. Remember, an IUI cannula will always have a syringe attached at the end, and this will have a piston attached at the end. Also, if they give you a closer picture of the end, this is enlarged here. So this end, you can see there is a hole, right? So this is a hole, and this is actually very sharp. So this, what we do is basically we put this inside the uterus through the cervix. This is very thin, so cervical dilatation is not required, and we rotate it 360 degree, and this sharp edge is used to scrape the walls of the uterus, not very deep, just superficially. And this blue inside thing is withdrawn by this knob. This is withdrawn. So the curated materials are getting sucked in the tube, and once the suction is completely done, we can just take out the tube and push this back, and the entire collected endometrial sample comes out through this and goes into the formalin vial. So this is basically uterine biopsy people, uterine sampling people, which is used for office endometrial biopsy. Office as in clinical chamber. Office endometrial biopsy. So this is uterine sampling people. Coming to another question, which was a rather direct question, identify the instrument. I think the image that was there from my sources confirm this was the image. So, but I have put 3. This is a very small instrument, and you can see the shank is really small, as a normal size blade with the very small shank. So, this is known as the Wrigley's forceps. Or outlet forceps. A similar looking forceps with a longer shank, a more stronger grip handle, and same size of blades is a low forceps, which is given at the level of plus 2 to plus 3. This is given at the level of plus 4 plus 5 station. This is the Keyland's forceps, the only rotational forceps, Keyland's forceps or rotational forceps, which can be given at the deep transverse arrest at station 0. This is a mid forceps. Technically, and these can be identified by this particular typical lock. Can you see this box shaped thing? This is the sliding lock. And this can only be seen in this particular forceps. So coming to the last question that I have collected, this kind of an image was there, whether it's an ultrasound image or a schematic image. So they were asking about the low-lying placenta. So let us just discuss the placenta previa grades one more. Placenta previa grades one more. So if the placenta is coming to the lower uterine segment, is coming till the lower uterine segment, it is grade 1. If it is coming till the os, then it is grade 2. Till os is grade 2. If it is covers the os in a way that once the os dilates, there will be space for the baby, that is grade 3. So partial. And grade 4 is when the entire thing on the os is placenta, and if the os becomes 10 centimeter fully dilated also, the placenta will be presenting. So that is complete placenta previa. So this is the old classification, and new classification is based on TVS, on how far the placental age is from the, so less than 1 centimeter, 1 to 2 centimeter, 2 to 5 centimeter, and more than 5 centimeter is a normally located placenta. So that is how we define placenta previa nowadays. This is an old classification but useful and often asked. There was one more question on cervical cancer and pap smear, what kind of prevention it was, but I think that will be better dealt by our community medicine faculty. Thank you. I hope you did very well, and with the hope that you will all pass very well, I welcome you all to the Indian Medical Fraternity, and of course you will do PG. So start preparing for your PG, because this is the peak time. You have read all the topics, you have read all the 19 subjects, you have just cleared an exam which is at the level of PG entrance only. So start preparing for PG entrance so you can clear it off as soon as possible. Stay tuned to GAME. Thank you.